Thank you. It is now my pleasure to be able to introduce Dane Servine, who's the Program Chief for Children's Services for the County of Santa Cruz. It's good to see you again, sir, and I'm grateful that you're here. Thank you so much.
Thank you to the senators and the committee. I really appreciate, having been in children's services for a long time, your caring about this issue and really bringing to light some really important things. So I think I'm here to talk a little bit about
what you've been able to do in Santa Cruz.
Yeah, and where the rubber meets the road is often our actual clinical staff meeting with families and trying to craft solutions. I'm also the chair of the Bay Area Children's Systemic Care Committee and have been involved in these statewide issues for many years. I think I am here to talk about and give you a little glimpse of what is working, as well as really appreciate, the glass is both half full and half empty, and if we can keep doing the good work we're doing, that will be great. So many counties, I just want to say, like Santa Cruz, have active MOUs between mental health and child welfare services. Many do, to screen, assess, and treat foster children and youth. Since one of the key things I've seen in all the reports and heard here is really one of the main issues, and it is ensuring a rich treatment and psychosocial environment within which the medication issue is addressed. So what do we think is happening? I know that if we look at, in Santa Cruz and statewide, at the EQRO reports, as an example, many counties like us, we have a 98% 98% penetration rate for foster youth age 6 and over. It's a little lower for 0 to 5 children. That's compared to a statewide average of 58%, medium counties about 61%. What does that tell us? Well, when I look at the national survey done in 2009 that's reported in some of the congressional reports, they cite 46% of foster youth in the general foster youth population might be expected to have mental health needs, 70% in group residential care. Advocates like me might say, really, it's 100%. You can't be removed from your home without having some extreme trauma happen to you. Nonetheless, what does this tell us? Well, looking at the glass being half full, I'd say ever since 1989, when we first began building children's interagency systems of care, we've gone from 0. When I first started, there was no services, really, between foster children and mental health. And now we have an immense system that's really been developed. We're only about halfway there. But we're in the ballpark. When I look at this data, the EQRO data, we're in the ballpark. So where do we go from here? I think every county should do a couple of things that we've done. We are not unique in this. Many of my colleagues are doing this. But we immediately, when the articles came out in the paper, did a review of every single foster child receiving medication. In Santa Cruz, it's only 9%, so that's fairly comparable to the 6% general population rate. We looked at every single medication by every single child, and we were a little surprised, actually, at just in our locality about how appropriate those medications were as an adjunct, because every single one of those children were receiving treatment. So it was done in a psychosocial context. So I support that 100%. We need to be measuring what we're doing. If you look on our Santa Cruz website, we've been measuring outcomes, clinical and otherwise, for kids for 25 years via the CBCL, the Ohio scales. We're shifting to the CANS also. I really support that as a statewide necessity. I think if we were going to do one thing, it would be not so much using a hammer to the nail of a single issue around psychotropic medication use. That's really important. A hammer is very important. But make sure we have a full tool belt, really ensuring that it's the treatment and psychosocial access for all foster children, within which you can see if the medication is appropriate to that larger family's needs. And there are many counties like Santa Cruz who are serving from 50 to 90% of foster youth already. Let's increase that. Let's keep building on that. So I think we're doing a lot of things well, and I applaud the efforts to move us towards an even more robust system.
I appreciate that. Thank you very much. And just a few follow-up questions. And so Santa Cruz County saw some challenges as it was reported in the press, and then did your own self-review. What do you do for counties that don't do that?
You know, every county can do that.
No, I understand, but I think if we can be candid, I think you're the Santa Cruz. A lot of times, at least with this issue, is the exception and not the rule. And so, just any thoughts on your colleagues and how to be able to get your colleagues at the table to be able to do some of the assessment that you have done at home?
I do know from our federal system of care efforts in the 90s that we were a part of, that states that are a little smaller, you can do a little bit more comprehensive approaches to things. California is very large, 58 counties, 2 state agencies. I am a big believer in interagency collaboration and statewide-ness when it comes to children and youth. Otherwise, we are going to get oases and deserts that aren't working really well. So I think the efforts, as an example, that the KDA lawsuit has spurred of better integration and cross-collaboration at the state level and ensuring that that's occurring at the local level, including more robust reviews through the EQRO process and the other kinds of reviews that are done, often focused on adult mental health issues. Existing structures are there that really won't take a lot to ensure that these questions get asked and the data gets reviewed.
Absolutely. The other piece is that I want to talk about, a lot of folks use the term making sure that youth get the right services. And that could be a broad definition. That could be anything from a child getting a 15-minute therapy session once a month to having multi-therapy sessions during the week. How do you work on that as a county to determine what is the right approach? Because I think a one-size-fits-all approach simply does not work.
Yeah. You know, the systemic care approach, just to use colloquial language, where in 1989, we kicked therapists out of the office, gave them tennis shoes, had them go into people's homes, into the jails, bringing intensive services, case management, and treatment where the kids were, using traditional therapeutic approaches, including medication and psychiatric services, as simply menu items on a much larger psychosocial approach to wrapping care around children and families. I'm a big believer in that approach, and I think some of the recent focuses on whether you call it a wraparound team or child and family team, child and family team for every foster youth, not just the subpopulation, but the larger population would be great. And there has to be an equal investment in ensuring, I can tell you from my experience, from my clinicians, that to do the more robust child and family team process for every foster youth requires more than what we're doing now. And we also have a tremendous workforce issue. So thank you for continuing to help support not only more therapists, God bless, we need more child and adolescent psychiatrists, which is a rare commodity in the country. But we need our graduate schools to be teaching the kind of work that we are talking about here, wraparound services, not just traditional psychotherapy.
And not trying to be pushy in regards to time, but we're just running a little late on the panel, and it's mostly my fault. But I do have one last question on the grievance process, if you can answer this 30 seconds or less. Can you talk about how you work the grievance process within the County of Santa Cruz and get that out there to youth or their representatives?
If you're talking about on the mental health plan side, any grievance that gets filed gets reviewed by our core management team through our regular quality assurance process. We also, that's a formal process that youth may not be very familiar with. So we do actively link with CASA, and we link with our family advisory, foster youth advisory councils to just try and provide any doorway in to get that kind of feedback. And then we review it at our core management team.
No, I appreciate that. Thank you so much. And thank you for the 20 questions that I've been throwing at you. want to go to Mr. Castrillo real quick in regards to medical records that you had brought up. And one of the items that you had said that would be helpful, obviously, is electronic medical records. Makes it much simpler to be able to stick with the individual. Just at the core level, one of the biggest challenges that we see are those medical records continuing to be attached to the youth. And let alone having to go to another group home in the same county, but if there's another placement in an additional county, to ensure that that medical record sticks with the child. And you had said that's been, I was inferring from one of the areas of solutions that you'd like to be able to seek is having those electronic medical records. It's been a challenge for the clients you represent to ensure that that is with the youth when they're being evaluated.
Yeah, absolutely. As mentioned earlier, the notion of different counties, different departments talking to one another, the fluidity of that information transfer is an issue that we run into regularly. If it was, we just have a robust electronic health record program, that probably wouldn't be just the sole solution, right? We have to make sure that the folks that are in charge of maintaining and providing that medical and healthcare information history are making sure it moves as a youth changes placements, that it's getting put into the right hands when there is a consultation, a follow-up appointment, when they change therapists and they change providers. So, the notion of how do we get different departments, different counties to talk to one another is maybe the overarching kind of issue there. But certainly the greater prevalence of electronic health records to be able to facilitate the documentation and transfer of it is, from our perspective, a big part of it. Yeah.
I appreciate that. And the reason I bring that up is could not imagine moving to another county, going to a doc, and that physician not knowing about my medical history. And all of us would be upset beyond belief to have that. Yet it's accepted in many cases, the 63,000 foster youth that are within the system, of being able to track just the basic need of a medical record. That is how deep a dive that we need to do to ensure that we're bringing forward appropriate reforms. So I want to be able to turn it over to the Senator to see if you have any further questions or follow-up comments for the panel before we transition.
I don't know if I have questions, but maybe a comment on following up on the EMR. I think the biggest disadvantage that the county has to doing that, it's not being reimbursed by the federal government, whereas the federal government under Medicare is requiring physicians to have EMR by, say, 2016. So because the state, I'm assuming, because the state reimburses the counties don't have an incentive to do some type of electronic medical records, and maybe that's something, again, we should be looking at is accountability and transparency, because we expect that in private health care. We expect that in managed care. Absolutely. Department of Managed Health Care, when a plan signs up to see patients, we expect that of them. Maybe that should be part of the conversation as well.
I think you're absolutely right. We're really grateful for all of you for attending today, and thank you so much for your testimony. It's good to see you. All right, thank you so much. Thank you, and great job. All right, we'd like to be able to move on to our final panel today. It's the Medi-Cal Specialty Mental Health System Oversight Panel. We are grateful that Karen Baylor is here, Deputy Director of Mental Health and Substance Abuse Services. She oversees mental health services for the Department of Healthcare Services. We have the incredible Will Lightbourne, who is just never has a shortage of items on his plate, and at least you don't have the continuum of care reform that you're working on as well. From the Department of Social Services, of course, we have Patricia Ryan, the Executive Director of the County Behavioral Health Directors Association, and the man, the myth, the legend, Frank Mecca, Executive Director of the County Welfare Directors Association. We're going to be kicking off this panel with Ms. Baylor, who's the Deputy Director of Mental Health and Substance Abuse Services. It's good to see you again, Ms. Baylor.
Thank you. Thank you for the opportunity to present before you. My role here is really to give you a high-level overview of what DHCS's responsibility is with the counties. As you know, we do have a contract with each county, and we are responsible for making sure that there is access and quality services at each county. We do have, as you've mentioned before, a number of areas where we are responsible in monitoring each county plan, and that is the triennial reviews, the external quality reviews. We do focused reviews on the MHPs, the counties, when we hear of significant concerns or noncompliance. There are reviews of questionable Medi-Cal billings, and then we do have fiscal audits by our audits and investigation. I want to touch briefly on the triennial reviews. Those are reviews of the county, and we go in and do pull charts, and then we also do a systems review. Each year, we've been doing this for quite a number of years now. We have a compliance advisory group where it's made up of stakeholders, some legislative staff, a number of other folks who come together once a year and look at our compliance protocol and then provide feedback. We constantly are changing it every year. We add more, take away some that is not useful, and are constantly trying to improve on the compliance protocol. We recently had our compliance advisory committee meet and are going to have more changes to that protocol, and we'll post that on the website once that gets finalized. But we are adding in a number of items into our compliance protocol this year, and that is we want to know how the mental health plans, the counties are monitoring the safety and effectiveness of medication practices. We want to make sure that all the counties have policies and procedures in place regarding monitoring of psychotropic use. Does the policy specifically address monitoring psychotropic medication use for children and youth? And then obviously, are they seeing any quality of care concerns, and how are they addressing those quality of care concerns at the local level? We also look at the medication consent forms, which have to have a reason for taking the medications, reasonable alternative treatments that were offered, and then we also look at the type, range of frequency, amount, methods, and duration of the medication and probable side effects. We also are adding to this year's protocol about the JV 220s, which I'm sure you're familiar with now after many of these hearings, and making sure that those are in place as well. So as I said before, while it's not perfect, we're a work in progress, and we constantly strive to make changes and improvements. As mentioned earlier, we do have the quality review, and that is responsible for looking at quality improvement activities, timeliness, and access to mental health care. We also validate the following performance measures, the performance improvement projects, and consumer satisfaction. So KDA this last year, we asked EQRO this last year to look into the KDA implementation efforts of each county. EQRO looks at a system review, and they don't do chart reviews. So we're really looking at EQRO to do the access and timely access to care reviews. As you spoke earlier, the 1915B waiver was approved for 5 years, which we celebrated, but they did have some requirements. And let me go through some of those, which we're already working on to put in place. So the state has to make readily available to beneficiaries, providers, and other interested stakeholders the mental health, what we're calling a mental health dashboard. And that will be with a number of outcomes. We have a metrics work group that is working on data elements that will go to that dashboard. We also want to look at the dashboards that are already in place on the managed care side to see if we can do some similar structure so that they're easier to read. The state has to require each county to commit to having a system in place for tracking and measuring timeliness of care, including wait times for assessment and wait times to providers. The state will provide the EQRO quarterly and annually reports and all of the performance improvement projects to CMS. We'll publish on our website any of the plans of corrections that are done after the triennials, and then want to make sure that we have all information required is published and in place according to the standard terms and conditions of that waiver. As we also talked about, there is a contract between the state and the mental health plans, and we have two contracts. One is for specialty mental health services, and the other is the performance contract, and I know that that gets confusing, but we do work very closely with the County Behavioral Health Directors Association, and they work closely with their County Councils Association on the terms that are in that contract, and we review that contract every year. There isn't anything specific in the contract. There's not specific language that is in prescribed psychotropic medication, but the contract is really broad-based and used for all beneficiaries, birth to death. But we do have the following requirements pertaining to medication that is prescribed, that each of the county's assessments must include information about medication that the beneficiary has received or is receiving, and then there needs to be progress notes in the chart that include the frequency of medication support services and how services are provided to reduce impairment, restore functioning, and prevent significant deterioration. And then finally, the performance contract, just high level, is really on non-Medi-Cal programs, so that's our MHSA. We do have a PATH grant from the federal government, which is for homelessness, and then the SAMHSA block grants.
No, thank you so much, Ms. Baylor. I just have some questions really quickly. If we could do follow-up, does that work for you right now?
Whatever you'd like.
All right. Again, I really appreciate your time. I think on the just wanted to be able to address the EQRO. And what we've seen in regards to the reports is that graph, and I'm sure you've seen it, about the steep decline in regards to having those mental health plans for foster youth. And I know you had just mentioned about that, and I think that's back 2010.
Right.
So I understand we're using that, but can you talk about that, of that declining access, if you will?
Sure. We've had a change in our providers from who does the EQRO this last year, so we have a whole new contract. I think one of the areas that CMS has been concerned about with the Department of Healthcare Services and was part of the negotiation with the 1915B waiver is, frankly, we weren't doing enough with the EQRO reports, and we weren't doing enough on the follow-up on the plans of correction. And so that's some of the efforts that we're working on now, is to make sure that there is information that is gathered, that is posted timely, and that we are doing more follow-up on that. So while we haven't done as much as we could have, we are definitely focused on that in the future. This next coming year, the round will start again here in October for the triennials, and that's another thing that we want to make sure that we're getting posted and that there is transparency for the triennials and for the EQRO, that those reports are readily available to anyone who wants them on our website. We've made some improvements to the mental health website, so it's a little bit easier to follow, but we also want to make sure that we are following up on the EQRO reports, because we admit we haven't done as much as we need to have done.
So the other item is that when we measure, so right now, the department is measuring the percentage of youth receiving mental health services on an annual basis. But where I believe we're challenged is we don't measure the success. So it could be, and I'm making this up right now, it could be they receive 50 minutes a month. But we don't know what that has meant, whether it's positive, status quo, or we're continuing to see a decline. And what we've also seen, particularly with providers, with group homes, is a challenge to be able to look at mental health services increase in psychotropic medication. So I guess what I'm trying to do is dive down and how do we measure success? So I appreciate where you're going on this, but I guess what are the indicators for success, and how does the department know that we're actually moving the needle?
I think that's a great question. I'm going to look to Lynette to help out a little bit with this, but I think that's part of our performance outcome system that Lynette can give an update on. I know that there are a number of counties who have great models out there. I know Patrick, Mr. Gardner, believes that Kansas is the model and tool to use. We have other counties who use other tools and have spent lots of money on putting all those tools into all different languages and collecting that data. I think it is incumbent upon the state to make sure that we are collecting all of that information statewide and want to be able to use our performance outcome system. But if you don't mind,
I would love that, and I think just a follow up on that. When we talk about data, I think we only have, out of the 56 mental health systems, because we have 2 smaller counties that are working with neighboring counties. I think a total of 4 are part of the data sharing agreement, and that is where we're supposed to be gathering data. And so, what I'd like to be able to do, and just finish this thought here, is I'm going to give you my own editorial. The state is unable to measure success. And to measure success, we need to have data variables. We only have 4 counties that participate in that. And if it's those guidelines are not mandatory to ensure that we are collecting that data, how do we ever achieve success and move the needle?